Well, welcome back to the Feeling Like a Snack podcast, brought to you by the Protein Snack Shop. We are excited to have a very special guest remotely in North Carolina, Bailey Wilkes. And Bailey was a phenomenal speech pathologist. And so we're going to kind of turn it over to Bailey. Bailey, tell us a little bit. Yeah.
Hi. Yeah, my name is Bailey. I'm a speech pathologist in Wilmington, North Carolina. I've been practicing for almost 17 years since I finished grad school. And the majority of my career has been focused on working with patients in the adult and geriatric population. Currently, what I focus most of my career on is dysphagia evaluation and treatment.
That's awesome. We actually have a product that we're working on along those lines. So tell us just kind of your progression through your career, what your patients look like, the prevalence. I just read quickly. Um, I was very shocked by uh, the prevalence of some kind of difficulty swallowing in an adult population. It was way higher than I thought it was.
Oh, definitely. And a lot of people don't even know what the word dysphagia means. Every
Yeah,
time
thank
I
you.
diagnose this, I have to provide the um, uh, definition of it, which dysphagia is just a swallowing impairment. There's different phases: the oral phase, the pharyngeal phase, and the esophageal phase. That kind of break it down into three basic areas. So dysphagia affects a lot of people. The research shows that like 50 years old, you start to maybe experience some maybe minor swallowing changes. That's kind of uh, typical of, let's see, I had written down a few facts. Because I was surprised that 7 to 10% of the just normal aging population experience some sort of swallowing difficulties. The most common reason for having dysphagia is either like a neurological impairment, maybe autoimmune disease. Parkinson's disorders and head and neck cancer represent a huge population that I see. With a stroke, a lot of people will have dysphagia acutely, but a lot of them will also, uh, get back to kind of baseline as far as their swallowing or just have like minor impairments. But with disorders like Parkinson's disease, which is a progressive neurological disorder, that's about 80% will develop dysphagia by the um, end of their life,
My
as
pops has
this,
got that, so it's very real. And
absolutely.
which is a great question for you. Um, Often that becomes the point where they pass away because of aspiration, right? Because they have
Aspiration pneumonia. And aspiration, means entering the lungs rather than entering to the esophagus, which leads to the stomach. Aspiration occurs a lot in people that have dysphagia, and that can lead to aspiration pneumonia, which can be deadly. It's
Can you
hard to treat.
explain the pathology of that? Why does that occur? I mean, obviously, I know it's got to do with muscle tone in the neck, but what actually, and I mean, I'm sure quite a few folks have relatives in the same camp as I do. But what about those diseases actually causes you to aspirate into your lungs instead of the normal swallowing process?
Um, well, there has to be at the beginning of the oral phase, there has to be an adequate labial seal or lip seal to kind of keep the bolus, which is whatever you put in your mouth, liquid, solid, whatever, that is considered a bolus. There has to be good lip seal. There has to be a good or adequate lingual motion in order to transfer the bolus from the front of your mouth to the back of your mouth. And whenever there's a delay or a reduced sensation to something that maybe spilling down prematurely before they've initiated a swallow, or maybe there's,
Ah,
yeah, so that can occur in the oral phase. The pharyngeal phase is responsible for a good like pharyngeal squeeze, which is when all the internal muscles kind of squeeze together, strip the food down, so it goes into your esophagus. Um, if there's a delay in the swallow initiation, or if there's not good, it's called epiglottic inversion, which means epiglottis is the cartilage kind of at the base of your tongue within the larynx, which is at the beginning of the top of the larynx, and its job is to kind of be like a flap. And when it's open when you're talking, but whenever you swallow, it closes down over your larynx, your windpipe, to protect it from food and drinks entering it, obviously unintentionally.
It's crazy how much we take all that for granted.
I
You
know
know, I've
it's
never had
Yeah,
somebody
yeah.
like explain it so thoroughly before. And it's like, you don't even realize that that's the process that you're going through every time you're drinking
Yeah.
or eating or,
hmm
yeah, that's
And
crazy.
sometimes it can be a soft gel. I see that a lot too. People have what's called like a Zinker's diverticulum, it's just like a little pouch in their upper esophagus. And what can happen is they swallow and everything looks good here. It hits that pocket, it comes back up, and then it's got to go somewhere. So sometimes they'll regurgitate, sometimes it'll go into the lung.
Yeah, so you know, like I said, Parkinson's is very real to me. My pops is going through it, and he's approaching kind of the latter stages of it. Can you tell the viewers um, that just the dynamics and why swallowing becomes an issue that can cause death with aspiration? Can you just walk us through the whole where that even comes from? Because I was thinking, you know, I mean, you know, as a pharmacist, I have no clue of any of that stuff, but I've always wondered how that happens, you know, like what the process is.
Well, typically what I've seen is that if the Parkinson's disorder is diagnosed a little later in life, then dysphagia doesn't become as much of a let's see, deadly issue because the disease they're going to pass away naturally almost or from some of like comorbid etiologies that advancing dysphagia and advancing Parkinson's stages. A lot of people aren't diagnosed in a timely manner because some of the symptoms or signs can be kind of subtle. Shuffling the feet, maybe the
Yeah.
voice starts to get lower, hand tremors, or they'll be diagnosed maybe as essential tremors because it's people don't want to, neurologists especially, they kind of will just kind of keep a monitor on their signs of Parkinson's before they make a definitive diagnosis because there's a lot of other disorders that kind of might be similar as far as the signs and symptoms, but essentially as the body starts to kind of shut down muscularly. Just like every other muscle, we have a lot of muscles in our larynx and our tongue, or not larynx, but in our pharyngeal phase around the larynx and our tongue, that are involved with swallowing. Uh, Taste changes occur because a lot of people start to experience some dementia, and medications can make things taste differently. I see a lot of people that are on essential medications for Parkinson's, which is carbidopa. I always say it wrong. Levodopa.
Carbidopa,
You say it.
levodopa. I
Yeah,
got
there
it.
you go.
Now we're in my
um,
world.
so it's really obviously it can be extremely effective for treating movement disorders, from Parkinson's, but it also causes a lot of xerostomia, which is chronic dry mouth.
hmm
So that can lead to dysphagia as well.
Makes sense.
But essentially, there's cognitive decline, there's reduced respiratory support and lower abdominal breathing, and that causes people to not be able to cough as hard if they need to protect their airway. There's reduced sensation in their swallowing, but signature to me, I've seen a lot of what's called pill rolling with the tongue, which they're trying to swallow and the tongue's just kind of moving like this instead of moving like this. And so there's that discoordination, and then there's a swallow delay typically as well.
So I thought it was very interesting. I went to my dad's first appointment and they gave him all kinds of vocal exercises.
hmm
So obviously our vocal cords must be involved. Is that just keeping the muscle tone? And but I mean, and it's funny because I could actually not funny, but I mean, the stuff he had to do he thought was silly, but I could
Yeah.
actually tell the difference. I could have a phone call with him one week,
hmm
and he was crystal clear, and then I could call him the next week, and it's that constantly having like mucus in his mouth, and I could
hmm
barely um, hear him. You know, it was hard to
hmm
understand what he was saying. So
Yeah.
tell us a little about that phenomenon. So that's strengthening the vocal cords. Obviously, probably everything in the neck plays a part in our swallow, but
Yeah. Yeah. Definitely. It's all kind of connected. If someone has a paralyzed vocal cord, they're more likely to aspirate because the vocal cords are like the gatekeepers to the What does this look? here's 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 the opening to the trachea, and here's the vocal cords, and they
Yeah.
open up to talk, and they close to swallow. But if so, yes, the vocal cords do play a factor in that. But in voice treatment, evaluation is the weakest I am, and as far as my scope of my career and my experience, I'm not a voice expert. However, I do understand the basic logistics of voice treatment. It's more specialized with Parkinson's. They do physical therapy is approached kind of differently. Something called Lee Silverman Voice Therapy, LSVT. You have to. It's very expensive to be trained in it. And that's probably, and I've worked in nursing homes a lot, and they're not really going to reimburse somebody to go get trained for specialized voice treatment.
Sure.
They're just really trying to keep the patients alive and keep them from falling on the floor. But LSVT is like a tiered voice treatment program where they evaluate loudness, quality of voice, respiratory support, all those things, and work on think loud, like project your voice, because they don't recognize that they're speaking very with low volume. They don't realize they're whispering. So you kind of have to teach them to yell and use their diaphragm or whenever they're talking.
So Parkinson's is a big part of your practice. Kind of and you said like stroke victims, kind of some other phenomenons. Walk us through all the different disease states and how that affects it, because I'm already excited. I'm learning a lot because it's crazy to just already what you've told us, how much goes into swallowing that we don't think about.
Well, and just how that affects their eating and their food and their nutrition and all those things.
Yes. So what I think I'm probably the most experienced at and feel like the most confident with is treating post-stroke victims acutely, home health, outpatient. I've done it all. But the best thing about stroke is typically you just get better. There's the brain's healing itself. It's not a neurological, like a progressive disease where you're not going to get better, but you just kind of modify, life to accommodate the progression, such as Parkinson's, ALS. So with the stroke, though, it's either it's like an infarct, which is like a clot in the brain, or there's hemorrhagic. Those are the two main types of stroke. And they can affect different parts of the brain, obviously, and then it will affect different facets as far as walking, talking, cognition, vision, balance, swallowing, a lot of different things depending on the part of the brain is affected. So a lot of the times, typically what I see is, especially, if someone is receiving some intensive therapy right after a stroke, there is significant improvement that happens just, spontaneously, or not spontaneous. What's the word I'm thinking of? Whenever it just happens naturally. I can't think of it now, but they're going to experience just some improvement that just happens because your body's healing. But a lot of it, they benefit a lot from objective evaluations of swallowing. So a FEES or a modified bear and swallow study to assess, like, where is the problem? Is it here? Is it here? Whatever. And target those muscles with specific exercises, and also developing or trialing different maneuvers to develop like a strategy plan for compensatory strategies that the patient can follow. So, but a lot of times too, patients will have long-term dysphagia. Quite often, I went to the National Library of Medicine, and I was kind of looking at statistics because I kind of have my idea, but I wanted to see kind of how close I was to it. And I've heard in the past that 80% of people that have had a stroke will have some form of dysphagia, but the statistics now say 50%, but still that's ridiculous. It's super high.
That's really high.
So yeah.
There's so many different things that can happen with a stroke. There was a girl that worked for me at Target when I was in management there, and she had a stroke, and she just started working for us, and she had an accent. She had a German accent. And I would ask her, I'm like, where are you from? And she's like, I'm from Alabama. I'm like, no, you're not. She's like, I actually had a stroke. And after my stroke, I can't talk normal. This is how
Mhm.
and that's super rare, right? When it
Yes,
comes,
very rare.
very rare. And she, because it was so rare, she actually could connect with some other people who had the same sort of
Mhm.
phenomenon. And there was a girl who had an Asian accent, and like that's just how their
Wow.
brain like reprogrammed
Well, I kind of
itself.
want
Yeah.
like a British accent, so maybe I'm gonna.
Yeah.
This
But
seems
that would
pretty
be
cool.
so like I love to hear her talk. It was just I just
Yeah,
it was crazy to me.
that's incredible. Yeah, no, that's very rare. I've only read about it in textbooks and learned about it in grad school,
Talk
but
us through what does a typical day, week look like for you? How you evaluate? Obviously, big chunk of that's evaluating patients.
Mhm.
What are the different? I mean, I've learned that the vocal training for Parkinson's just because my father. But what are some other treatments and how you walk through people or retain as much of the muscle tone, the swallowing process as possible? So kind of walk us through your week, your day, and then
Okay.
how you help people get better.
All right. So, what I do 5 days a week, in the mornings, start at 7:30 and usually done by 10:30, is I do all the outpatient modified variance swallow studies. I feel like in the whole Southeast North Carolina area, but for various counties because New Hanover, is kind of a hub in comparison to our surrounding counties, to offer GI, ENT, head and neck, radiology, radiation oncologists, maxillofacial surgeons. We have those specialists that other places, other towns don't have, and so they kind of flock here for medical care, or at least to see a specialist for a consult. Modified barium swallow study is a video X-ray of the swallow in a sagittal position, our view, and there's just a minimal amount of radiation that's used when the patient's swallowing. They swallow barium as a contrast so that it shows up on the video. Um, and you assess different consistency liquids, different textures. And usually I'll do like a barium tablet to see what it looks like when someone swallows a pill. So I do that every morning. I up to about 20 a week. And then in the afternoons, 4 days a week, I go to an outpatient clinic and do what's called like clinical swallow evaluations or bedside swallow evaluations. So I'm just watching the patient, how they eat, what it looks like. Do I see any, disorder in their tongue movement or lips or cheeks? And I kind of feel for, is the swallow, can I feel anything? What's called like hyolaryngeal elevation. And, the clinical is a good, baseline as, or not baseline, but as a screening pretty much, but nothing kind of beats an x-ray of actually what's
Sure.
happening. So I'll see patients that I evaluated with a modified, and then I'll see them for, an outpatient treatment, program or whatever. And so depending on the area of the swallowing impairment and what I see it to be factors, is it reduced base of tongue retraction? Is it reduced pharyngeal squeeze? Is the upper esophageal sphincter not opening enough? Is the epiglottis not inverting enough? The hyolaryngeal elevation not occurring as well as it should? That would compromise their airway and pose risk for aspiration. So depending on the disease that they have or the disorder that they have, regardless of etiology, TBI, ALS, stroke, Parkinson's, lots. But sometimes it just happens like with dementia too, with Alzheimer's. But it's not because of disorder in motility. It's more a disorder in cognition.
Really? So
Hmm.
even though that's a fairly involuntary process, right? I mean, I feel
Hmm.
like you swallow without really thinking about it.
Yes,
That's weird that
typically a normal swallow. Yeah, you don't really
yeah,
have
so
to think
that's
about
weird that you would lose that
it.
with cognition. It's like when we lose cognition, we don't stop, typically quit breathing. That's just a weird phenomenon to me that would affect them.
Yes, definitely.
What is the barium swallow? Is that showing just the whole process of how things move through the esophagus, the speeds, the opening of I mean, what kind of
Yes.
information do you get from that?
I get that pretty much. What I'm trying to determine is Are they aspirating? That's what the doctor's sending them for. Are they having recurrent pneumonias that they're not quite sure what's causing it? Are they having like a globus sensation, which just means something feels like it's stuck in your throat, and it could be here, it could be here, like way low into your esophagus, and the esophagus doesn't have as many nerves as most parts of the body, so it's hard to localize it accurately. So I'd say a lot of my patients are experiencing like GI issues, but they come in for the modified first because the doctor wants to know if they're aspirating. If maybe they're not aspirating, but they're having what's called penetration, which means something enters the airway just under the epiglottis. So here's the opening the airway,
Yeah.
here's the epiglottis. You want it to close down and everything pass into the esophagus. But if something kind of goes under the epiglottis, that's called penetration. If it passes the vocal cords, it's aspiration, even if it just passes a little bit. But with penetration, even though it hasn't become aspirated yet, it can lead to aspiration if there's a significant amount, if it's deep enough. There's certain normal levels of penetration, which is flash penetration, or a level 2 on the penetration aspiration scale for any of my little speech pathologists out there. But it enters under the epiglottis and immediately spontaneously clears. It's pretty quick without having to cue the patient to clear their throat or something like that would clear it. So that's it. Aspiration, penetration, and I'm also looking for, is there something happening lower? Like I said, like the diverticulum, where something might shoot back up, and even though they didn't aspirate during their swallow, something comes up and they aspirate afterwards. Or if there's a significant amount of residuals after they swallow that remain on the base of tongue, the posterior pharyngeal wall, the vallecula, which is the space between the base of tongue and the epiglottis, is it in the piriform sinuses, which are here essentially.
It's still blowing my mind how complicated swallowing is. I never had any clue. So, what is the prevalence? And this is kind of what I was thinking as I've walked through this with my father. What is the percentage of death from aspiration typically? I mean, I know you don't
Mhm.
have 1.9% of all diseases, but is it high, low? Is it pretty common?
It all really depends on a lot of factors because someone that is non-ambulatory, someone that is bedbound, someone who has like other, just like with COVID, it affected some people a lot different than others because if you had diabetes or COPD
Sure.
or whatever, you might be more likely to die from it. So as far as aspiration leading to death, I really don't know like the figures with that, and I'm sure it varies per population. Some people will aspirate once and be in the hospital, and some people aspirate every day chronically and never get pneumonia. So it's pretty amazing how different people's bodies respond. And so the more active and ambulatory someone is, and maybe they're more aware they are, like cognizant of this is what I need to do as far as strategies. They have good strong cough. Those are factors that play in their favor. But those patients with really poor oral cares, most people that develop aspiration pneumonia are aspirating in their sleep. It can be reflux. It can be just funk from their mouth or something they ate that's still in there. So I can't stress enough how important oral cares are for any patients that have dysphagia.
Wow.
So how does that affect their diet and like what they eat and
You kind of
It,
stole my thunder right there
how
because
they
I
eat
was
the
going to that. But
nutrition?
anyways,
Like, do you also coach
yeah.
them on that as well?
Yes, I also depend on nutritionist. My really good friend Mel, she was a huge uh, asset to helping determine. Okay, so this patient's going to be on a modified diet. Well, all of a sudden they stopped eating because they don't like the pureed food. What can we do? She's always pushing, not pushing, but are they ready to advance? They're still on a peg tube. Let's try to get them off, but you have to do it kind of slowly. If someone's on a feeding tube, there's two kinds. One that enters through your nose is nasogastric tube, and then a peg enter through your stomach. One is more temporary than the other. But with a feeding tube, it doesn't have to be permanent. A lot of people just have it just to get them through whatever they're going through, stroke or whatever. If it's it will have to be long term if there's a progressive disease, obviously. But with head and neck cancer treatment, a lot of times they'll put a peg in someone so to make sure they're getting the nutrition. There's a lot of nausea that comes with chemo, dry mouth, changes and like dyspepsia, changes in taste. Everything tastes like crap and metallic and all that from the radiation, they lose their interest in food and drink. And once you stop using your swallowing muscles, you will lose them. And so it's really important that throughout the entire process, they're at least having ice chips, water, whatever they can tolerate to keep, and doing exercises to keep those swallowing muscles, efficient. And but as far as nutrition, yes, there's different types of diets. Three, like four basic ones, I guess, would be pureed food, which everything is very smooth, like baby food. Dysphagia soft, which is kind of ground, moist, easy to swallow, but there is some level of chewing involved. Mechanical soft, chopped. So it's essentially just your. It's a lot. It's really important for people that have like that don't eat at a at a good healthy rate. Maybe they're stuffing too much in their mouth or they're missing teeth, those sorts of things. So dental soft is also a term. And then there's regular diet where you just kind of eat what you want. But then the ITSE, there's like 7 different levels of diet. It's too complicated to go into, but those are the basic ones. So presentation of food, the dietitian and the speech pathologist really work on, do we need like to encourage them to eat more with food molds going to make it look better? Here's a glob of pureed peas, but if you have a pea mold, it might look like real food. They're more likely to eat it.
Why did you choose speech pathology? What was it, a family member that you walked
Yeah,
through that was okay? Because I'm
yeah.
wondering.
Close family member. I watched him develop, struggling with learning to talk, sounding correctly, overall pretty significant language impairment, and had speech therapy from age, I think he was first evaluated at 2 or 3, on until he graduated high school. And because he supported afterwards with like social language, so higher level things and critical thinking and all that. And then went from nonverbal up until he was about 4, or if he was verbal, nobody understood him, to graduating, going to college, and got his degree. And so, and I see a lot of that, and I've worked with kids that, did not want to talk, did not want to interact, severe delays, and then a few months later, maybe good parental support. I can't stress that enough too, because twice a week speech therapy for 30 minutes is not going to do anything if parents aren't following through, generalizing what you're doing. So they need to be involved, because the kid doesn't know to practice their
Sure.
speech or whatever, how to play. But I've seen them, they're all, all A on roll, and they couldn't read, and they were in the second grade.
Wow. Now, do you do so? And I know this sounds ignorant, but so you're speech pathology. Do you do speech therapy as well? Do you help
Oh
through?
yeah,
Oh, so that is a part of your practice. Okay.
yeah.
So
Oh yeah.
did not.
That's to the spectrum. What?
No, I
How
didn't
many
know.
there?
That's cool.
Oh,
No, because
okay.
I guess we were
Yeah.
talking about analyzing all of the swallowing
Mhm.
and kind of going through that. But so
Mhm.
is another part of obviously part of your practice is helping with speech therapy.
Oh yeah. And
Very
I really
cool.
enjoy being able to do something besides just dysphagia. But dysarthria, which is a motor speech disorder, occurs after a neurological damage, usually like a stroke or a brain injury. If I hold it straight. So yes, speech therapists we work, or speech pathologists, same thing. The youngest patient I've ever seen was right around 8 months, and the oldest patient I've seen was 106. But birth to death we work with. So some people work exclusively in the schools, and that's what they like to do. Some people like to work home health. Some people like to work in hospitals. I really feel like I struck gold with my outpatient gig now. I've paid my dues in the past 17 years working in places that I didn't want to be.
Well, I've heard
So
Mel said you have one of the larger practices in the state. Yeah.
yeah, it's not my practice, but the practice I work for, yeah, it's definitely the largest in the area. So I get a lot of materials and access to things that maybe other therapists don't, because of where they work. So I feel fortunate for that.
That's
But
awesome.
yeah, yeah, articulation, phonological disorders, fluency disorders, stuttering, dysarthria, like I said, which is motor speech, different than articulation impairments. Phonological disorders are like multiple processes of impairments. Aphasia, expressive receptive, that occurs with loss of language skills. Maybe they'll not be able to read anymore. Maybe they'll have neglect to the left or the right, and they aren't able to see like their whole plates, or what's when they're writing, or reading and neglecting whatever's on that side. So memory issues. So yeah,
That's got to
different
be
things.
very, very, very the rewarding part of your practice to walk
Yeah.
It
people
definitely is.
To
through.
see where they start and where they end.
Yeah,
So
absolutely. It's
we
my favorite part.
follow, we love, what's the comedian's name? Drew.
Oh, Drew Lynch.
Yeah, Drew Lynch. So
Do you know who that is?
do you know who he is? Just watch his
He's a
comedy. You
he's
would, you'll
Drew
appreciate.
Lynch. He's a comedian that stutters, and
Oh, fantastic.
he's been through speech therapy and so forth, and so he really
Mhm.
doesn't stutter much anymore. But since he's kind of based
Mhm.
his career on that, he still
Yeah, he
does
had like a
it.
tragic accident to his throat.
Oh.
He was hit with a baseball,
yeah, softball.
softball.
Oh.
Hit the ground, went unconscious, woke up stuttering like crazy.
Wow.
You got to watch his thing. You would
That's
appreciate it as a
interesting.
speech
Yeah,
pathologist.
absolutely.
Just
I
walking through that seems cool. Like
Oh,
somebody's helped
yeah.
him so much.
There's so many factors that go into it. A lot of it is psychological. So it's not uncommon for a kid when they're learning to talk, especially if they're learning more than one language at a time, to have some hesitance. And they have a bunch of siblings, and the parents are like, "Spit it out! What are you saying?" That makes them, a little bit less likely to follow through or avoiding talking. A trauma can cause it. I had a patient once, I'll never forget her, and her stutter was improving a lot. That her first day at kindergarten was on September 11th, 2001, and she lived in Manhattan. And so
Oh my
when she lived
goodness.
close to the Twin Towers, and they literally just found her sitting on some steps, just traumatized at 5 years old with black smoke. No one knew where anybody was, so pretty traumatic. But she didn't stutter until then. And some people, get hit by a car riding their bike, and they'll start to stutter. Anytime there's any injury to the head, and I think to the face and the neck, if you get hit yourself in the face by accident or get punched in the face, you start tearing up because your body responds that way. Your nose starts running. The studies show, I've worked a lot on Camp Lejeune with Marines and sailors with traumatic brain injuries, and the guy who had his leg blown off was less likely to have um, PTSD than the guy who had like a blast injury, and they looked fine, but you couldn't see it's the invisible wound of war. But they would have post-traumatic stress because of the brain's response to anything traumatic happening to the
Wow.
head.
So you've helped a lot of people all over the spectrum.
Oh yeah, I've done it all essentially.
That is
Not much
amazing.
voice. I still second voice, like I said.
Well, so the takeaway that I was hearing through all that is all the talking that I like to do, Dana. See, I'm just helping.
Maybe you're in the wrong career,
No, it's helping my swallowing.
which you also don't need help with.
I'm mirror ready to saddle.
We can't tell you thank you enough. Just, obviously you and Melody are great friends, and she thinks the world of you. And just partnering with us to kind of help walk us through to help solve problems for your patients. We can't thank you enough.
Oh, thank you very much. It's been my pleasure. And to just get this information out there, because so many people I think need it, but have no idea what speech therapists do.
Yes. Well, thank
right.
you.
Thank you.
You're welcome. And I look forward to getting my peanut butter bar.
You
I'm
are.
sure gonna get
And
it.
we're gonna
Better hold
get
to
you. We're gonna
it.
get you a crop top.
Yes.
All right, cool.
Thank you.
Okay. Well, that was so great having her on there. I learned so much today.
I did too.
That was amazing.
I've spent time clinically as a pharmacist, and I did not know all the things that she just informed the audience about. So we're just really grateful to have her. We, as usual, thank you all for following us and listening to our podcast, and that we're so passionate about getting good information out.
Yeah. Be sure to share all the podcasts and like and follow everything that we do. We would appreciate it.